Hi, I'm Dr. Rajan Sagar from the University of California, Los Angeles. The question in front of us today is, are prostanoids effective in treating patients with connective tissue disease associated pulmonary arterial hypertension? The first thing that has to be recognized is that in patients with PAH associated with connective tissue disease, the treatment algorithm is identical to what is recommended for idiopathic PAH. And in that context, intravenous epoprostenol is the recommended first-line therapy in a functional class 4 patient with PAH associated with connective tissue disease, as it is with idiopathic PAH. Now, we have to keep in mind that there was a small number of functional class 4 patients in randomized controlled trials with ambrisentan, bosentan, and sildenafil. And these agents are, by guidelines, considered second line in the functional class 4 patient, again, with connective tissue disease associated PAH. And a common theme that you will be hearing from all of us in these discussions is that in the functional class 4 patient, initial combination therapy can also be considered. If you look at the patients who have scleroderma, are there any dedicated trials to looking at intravenous epoprostenol? And in fact, there was a very nice trial published in 2000 by David Badish and colleagues, which looked at intravenous epoprostenol versus conventional therapy, background therapy, if you will, in patients with systemic sclerosis associated PAH. The endpoint of this study included 6-minute walk, where there was a very robust improvement on the order of 60 meters plus in terms of the 6-minute walk improvement at 12 weeks. The study was not powered to show a survival advantage, and in fact, one was not seen. However, this is the largest study to look at intravenous prostanoid administration versus placebo in the systemic sclerosis PAH cohort. The long-term survival, again, as mentioned in this study, was not significantly improved compared to the conventional therapy arm, but again, the study was not powered for a survival advantage. But one can clearly see from this Kaplan-Meier curve that the survival, despite receiving intravenous epoprostenol, was on the order of 50% at 3 years, raising significant concerns about the prognosis of these patients, even on, quote-unquote, the best therapy that we have, intravenous epoprostenol. So with that in mind, I think it's important to understand and be aware of the data that supports the use of prostanoids in the setting of connective tissue disease-related PAH. Thank you.